Please let us know. And today we're going to talk a little bit about the assessing asthma control for patients, particularly with self-assessment as per the guidelines. And just a reminder that if you need to ask something, please remember to mute or unmute your telephone line. And this is the usual disclosure things. I do not have anything to report. Okay, there we go. So first of all, I'd like to thank Dr. Esmeralda Morales for sharing her presentation. She was very kind in lending me her slides. So today's objectives are to understand a little bit about the development of the asthma control test and the childhood asthma control tests, and become familiar with the clinical usage of these types of self-assessment questionnaires. And part of that is per the guidelines. So first of all, we want to overall figure out what are a patient's impairment and risk by looking at severity control, and then also looking at responsiveness to treatment. And as you know, at initial diagnosis, we classify their asthma as intermittent or persistent, and then in the persistent category, the severity of it. So at each follow-up visit, part of it is purpose is to assess control, and the categories in the guidelines are well controlled, not well controlled, or very poorly controlled. And the goals of asthma control are to reduce impairment and reduce risk for our patients. So the goal of reducing impairment is to try and prevent chronic symptoms, also try and prevent the frequent use of albuterol, most importantly maintaining near normal lung function and normal activity levels as possible, and also meeting the patients and their families' expectations as far as their asthma care. In reducing risk, we want to prevent recurrent exacerbations and minimize need for emergency room visits or hospitalizations, and of course prevent loss of lung function and provide the best bang for the buck, so to speak, the minimal amount of medications with the maximum effect. So one of those components of control is using, in addition to assessing symptoms while you're interviewing the patient, is also to use validated questionnaires. And there's several. There's the ATAQ, the ACQ, and then the ACT. And I think both the ACT and the ATAQ have also pediatric and adolescent versions. And as you can see, that under the definitions for well-controlled, not well-controlled, and very poorly controlled, they have different cutoff scores. And we're going to talk a little bit about the asthma control test and the child asthma control test to kind of explore how these questionnaires were developed. So for your familiarity, this is just an example of what the asthma control test for teens 12 years and older looks like. And basically they fill this out, this questionnaire on their own. And then this is the childhood asthma control test. Because we're dealing with younger population, there's also FACES to help children better qualify how they feel about their asthma. And also, this is designed more to how they're feeling today versus for the older children and adults, it's over the past 4 weeks. As part of the childhood test, there's also a section for the parents to fill out, and they get to look over the past 4 weeks. So the reason the asthma control test was developed is there was a need for a way to assess control with or without lung function, because spirometry is not always available in every office, and this was so there was a need to look at that and to see if you could provide a questionnaire that also looked at the multidimensional nature of the asthma control, meaning not only assessing symptoms, but also assessing how it was affecting the patients or their families' day-to-day life or activity of living, or if it was preventing them from attending school or missing a lot of work. And then they also needed to demonstrate performance against criterion measures of asthma control to make sure that things correlated. So this study was done by Nathan et al. And initially what they did is they got a group of 4 primary care clinicians and 7 asthma specialists together from different parts of the country. And they came up with 22 candidate questions which they thought addressed the multidimensional issues that needed to be looked at with asthma control, and also looked to try and see if they aligned with the asthma guidelines as far as assessing frequency of symptoms and use of albuterol and nighttime awakenings and that sort of thing. And this is an example of some of the survey items that were developed. The letters in the far right-hand column under the responses have to do with the type of scale that was used. For instance, for like the first one, asthma limit your usual activities, it would be frequently, sometimes, not at all, or never. And then how many days did your asthma limit your daily activities? It would be more number of days. So that's what those different letters mean. It's just the type of scale that was used for the answer. So they came up with the 22 items, and then they gave it to 471 patients of asthma specialists. And that's something to keep in mind, that these are folks who are already being seen by asthma specialists, and so they their answers might be a little, they might have more knowledge of their asthma than folks who maybe were coming into the emergency room or urgent care for the first time with an asthma exacerbation or something. So the inclusion criteria were they had to be older than 12, diagnosed with asthma, and literate in English. Exclusion criteria, they couldn't be in another clinical study or have other respiratory conditions, and the time of data collection was 4 weeks. And the comparison criterion was the specialist's assessment of control. So these were folks who are already coming to a previously scheduled asthma follow-up visit. And the asthma control was related by the specialist on a scale of 1 to 5, 1 being not controlled at all to 5 being completely controlled. And then the physician was blinded to the responses of the questionnaire, and then they also measured a pre-bronchodilator FEV1. And then in the analysis, they did stepwise logistic regression to identify the questions that had the greatest validity in correlating between patients who differed in the specialist rating of control. So the greatest validity in distinguishing between not well controlled at all, poorly controlled, somewhat controlled, well controlled, and I forget. Yeah. The classifications, sorry. And then they also had to control for the sites, because they found between the different sites, some of the specialists rated control a little bit differently than others. So to try and make it more consistent, they did that. They controlled for the site. The specialist control rating was skewed toward better control, which I thought was interesting, because they often, in a lot of studies, they've said that they found that patients sometimes overestimate how well their asthma is controlled. And then a dependent variable was a specialist assessment of controlled, and they basically broke those 5 classifications down into not controlled versus controlled. And then they looked at trying to see, well, what if the patients were overclassified by using that dichotomous variable, and they did a sensitivity analysis with 3 levels of asthma control to look at that, and found it was okay to use the dichotomous classifications. The questions that were chosen were significant at a p less than 0.05, and that they were chosen for the ATAQ survey. And then they looked at the reliability on this final subset of 5 questions. And they compared the questions, the results from the questions in relation to the specialist rating control, the FEV1, and if there was any change in therapy. So if they stayed at the same level of therapy or either stepped up or stepped down. And the hypothesis was that the scores would be higher for patients who had a better control rating per the specialist, and better lung function than in those patients whose therapy was stepped down. So basically, a higher score on the survey would correlate with good asthma control per the specialist rating versus a higher FEV1. So all the high numbers were good. Then they looked at, and I always forget what this ROC stands for, so bear with me while I tell you, receiver operating characteristics. So they wanted to look at how well the ACT was in screening subjects who had poorly controlled asthma. And then they also looked at comparing 2 different scoring options. So they looked at using a summing of the response for each particular question, so a summed total score versus a sum score of using dichotomous variables. So it was either a 0 or a 1, and then adding up the zeros and ones versus a 1 to 5 scale, if that makes any sense. And part of it is they were just trying to figure out if they could maybe make it easier for, in a busy office setting, to score the questionnaires. So of the 471 patients who completed the survey, 407 completed all of the items, so that's pretty good. The average age was 45.2 years, and I think it's kind of interesting, the age range was from 12 to 94, so that's interesting. And this is also very interesting. About 70-80% had categories of either completely controlled or well-controlled asthma. The mean FEV1 was about 85%, so their lung function was pretty good. And only about 12% of the patients were less than 20 years. So this is really looking at more kind of middle-aged category. And these are the some examples of the questions, and they looked at the odds ratio and the p-values just to give you an idea. As opposed to some of the other questionnaires, like I think it's the ATAQ, they also looked at how it was affecting work or school attendance, which hadn't been done with previous questionnaires. So they also looked at the internal consistency of reliability of the scale to make sure that it was valid within the questionnaire itself, and it was found to be 0.84, so it was pretty consistent. And then they looked at the scores to see if you could find cutoff points between the groups of patients that differed as far as the specialist rating of asthma control, the need for change in patient therapy, and the percent FEV1 predicted. So they were basically looking to see if the score that you got on the ACT, if there were certain cutoff points that would put you into the well-controlled and a higher FEV1, or not well-controlled in a lower FEV1 category. And overall, there was an agreement between the ACT and the specialist rating, anywhere from 71 to 78%, depending on where the cutoff points were. So this is how they were developing what the cutoff scores would be for your asthma is really well controlled, or maybe you need to discuss things further with your provider to see if you need to change your therapy or other interventions are needed. And the highest area under the ROC, which is the receiver operating characteristics, was a cutoff point of about 19. So a score on the ACT of 19 or higher correlated with good asthma control. And this is just a table which shows basically that the higher your score on the asthma control test, the more sensitive it was, and that indicated that the questionnaire, if you had the better your lung function, the better the sensitivity of the questionnaire for picking up if your asthma wasn't well controlled, I guess is kind of the way I look at it. But you would also get more false positives. And then if you look kind of at the other end, a cutoff point of 10 or less, it was not quite as good at picking up poor asthma control versus your baseline, basically. I mean, it tells you that your asthma is poorly controlled, but as far as picking up a difference between the last time, it may not be quite as sensitive. And below 10 there, that's where things kind of, didn't have great reliability for the asthma control test. So we had looked at that. So other assessments of control, there's the asthma control questionnaire and the asthma therapy assessment questionnaire. And how does the asthma control test differ from the other two? Well, in the development of this, they used the criterion measure of asthma control, so they actually looked at FEV1 and the specialist assessment of control. It's a little bit simpler to use than the ACQ. It's not quite as many questions, and you don't have to have FEV1 as part of the scoring. And it's a little bit longer than the ATAQ by a couple of questions. So this is an example of the ATAQ for adults.
It's a little bit longer than which one? The
ATAQ.
The ATAQ is a little bit longer than...
No, the ACT is a little bit longer.
Than the ATAQ.
Than the ATAQ
okay.
By, I think, 1 or 2 questions.
Okay,
I mean, it's not
it's 5 questions versus 4. Okay.
In the grand scheme of things, I don't think it's all that different. But this is an example of the ATAQ. And as opposed, it uses a 1.0 or 1 point as an answer, and then you sum it, and then the total points indicate where you're, if you're having more problems. So if you have the total points of 0, if you have a score of 0 to 4, it means that your asthma is not well controlled. So that's part of the confusion with using all these different questionnaires, is keeping track of what the number means as far as asthma control. So then they took the asthma control test and they validated it in patients not previously followed by a specialist, because remember the original study, these patients were being followed by specialists, and there was concerns that they might have a little more asthma knowledge because they may have received a little more asthma education. It was also validated by mail and home use, so in a non-clinical setting, to try and get an idea if it would be valid maybe that way, and by telephone. And it was also validated in Spanish. Now, the thing to know is these patients were in Spain, so that might be a little different than patients who might speak a different dialect or from South America or Latin America, just to keep that in mind. The childhood asthma control test, they looked at kids 4 to 11 years of age, and it's kind of a combo of children answering the questions and their parents' answers, because as you all know, young children aren't really good at recalling more than a couple days in the past. And there's also some concern that sometimes if they don't understand the question particularly, they may overestimate or underestimate what their symptoms are. So that's why it's they look at a combination of both to try and get the best idea of what's going on. So for this questionnaire, they came up at first with 21 items to determine which question should be used in the final test. And they went through several rounds of interviews with children with asthma and their caregivers. You can see the ethnic diversity here. And then they tried different levels of caregiver assessed severity. They also looked at different recall periods and scales. And as I said earlier, they decided to use the present tense for the child part of the questionnaire. And then younger children, they also found needed more guidance with the questions, so it might be a better response if the questions were read aloud to the child. And then younger children tend to have more extreme responses, so it was kind of harder. They had a harder time understanding neutral. And this is an example of the kid part of the pediatric questionnaire on asthma control, which, as you can see, has both the faces and word descriptions. Oops, sorry, went too fast. And then this is the parent part of the questionnaire. So this is what they started out with, and then they looked at trying to shorten it a little bit, because this stage it was 3 pages long, which is a lot to go over. They then did a 3-month cross-sectional non-randomized study in 343 children and their caregivers. And the children were being followed in 9 asthma specialty clinics. Inclusion criteria were a diagnosis of asthma, if they had symptomatic improvement with a short-acting bronchodilator, and or a history of documented reversible airway disease. And exclusion criteria was if there were other respiratory conditions. And basically, they had the parents and the children fill out study forms, a working questionnaire, and then other asthma controlled test questionnaires so they could compare and see if it was valid to them. The specialists were blinded to the responses, but also assessed severity of control and the medical regimen. And then the children had pre and post bronchodilator spirometry done. So that group was further subdivided into a development group and a confirmatory group. So the development group, that's where they looked at actually the development of the final questionnaire, and then they used the confirmatory group to test the final questionnaire to make sure that it was valid. And they used a p-value of 0.1 or less to select criterion to retain a question. The criterion measure was a specialist rating of asthma control, so like the other ACT, they divided the classifications down into well-controlled versus not well-controlled. And then they did an overall performance of the volume using the area under the curve from the ROC curves. And this was the demographics, and for some reason my little pink box moved. But under the caregiver education level, which I think is something that's important to look at, about 54-55%, actually, a majority of the caregivers had at least some amount of college or higher. So that's something to keep in mind. And also the majority of them were working, which I just point that out because that's the reality of life today. The ethnic diversity, most were of Northern American, European, white, is identified, self-identified there. And then here we're looking just at the numbers and how they fell out into the different categories as far as severity. So most of them were either moderate or mild severity of their asthma, and their FEV1 predicted was about 94%, so very normal. And the other thing is that the majority of the patients did not have a change as far as their therapy, so they were in neither the step down or step up category. So after things went through the developmental group, 7 questionnaire items were selected, and the children's scale was a 4-point scale and the caregiver was a 6-point scale. And they used a sum score like the adult asthma control test, and the cutoff point was 19 with a specificity of 74% and a sensitivity of 68%. And then they looked at the sum scores as far as could they discriminate between the specialist rating of asthma control, the change in the patient's therapy, and the percent predicted FEV1, which was very similar to the development of the adult ACT. And this just shows you the some of the statistics from the different questions and how likely they were to correlate for the child versus the caregiver. And then here's comparing the mean childhood asthma control test scores across the different groups and different asthma control. And you can see the p-values are pretty good in looking at the specialist change in therapy and assessment of asthma control and the percent predicted FEV1, but the FEV1 FEC ratio was not significant. And this is just a confirmation of the comparison of mean ACT scores across the different groups. And as you can see, the p-values were significant. So it is pretty good at looking at the different groups as compared to FEV1 and the specialist assessment of control. So here again are the cutoff points. The first table is a summary of the score for each scoring option and predicting specialist assessment of asthma control. And is like the ACT, the higher the score, the more sensitive it was. And the lower the score, the more specific it was. And then they also looked at it, so the first table was a development sample, and the second table is the confirmatory sample. And it had a pretty good correlation between the development group and the sample group, the confirmatory group. So that was just basically they validated that the questionnaire worked. And then this shows the comparison of the area under the curve for both the development group and the validation group. And you can see the curves are pretty close when you get to the higher sensitivities. And when you get to lower specificity, they kind of go apart a little bit, but I don't think it's enough of a difference to really... It wasn't considered enough of a difference to really be of a concern. This shows the different cutoff scores for the different categories. So basically the best cutoff score was a 19 for well-controlled asthma, which is similar to the adult test. The second cutoff point was they tried to identify what would be kind of the minimum score, which would indicate poor control. And this was a follow-up study, and they looked at 671 children who had data using the ACT. And then they also compared that to the specialist rating of control. And they figured out the cutoff point of 12 was kind of the minimum score that would assess poor control. Below 12, it was hard to say it was a valid test. The other thing that has been looked at is, does ethnic variation maybe, could you have a different response in different populations as far as what a good cutoff score for asthma control is? And so there was a study done by Shi et al. Where they looked at children who were of Mexican ethnicity in Orange County, California. And they used both the ACT and the CACT, and there were 151 participants compared to 41 controls. And in this population, they identified a cutoff point of 22 as indicating good asthma control versus a cutoff point of 20 for non-Hispanic controls. And so they had hypothesized that maybe part of it is maybe certain populations may underreport their asthma symptoms, or may interpret their asthma symptoms a little bit differently than a mostly white Caucasian population. So that's the development of the asthma control test in a nutshell. Basically, I think it's nice to know that they actually looked at all these different questions and compared it to the asthma guidelines criterion to try and make it so you don't necessarily have to have spirometry available. Are there any questions?
This is Michael Lentz from ABQ Health Partners.
Hi.
I don't want to complicate matters, but I've been trying to get the ACT embedded into our electronic chart at ABQ Health Partners. And I've been finding out a lot of information about copyright. And as I understand it, the under 4 ACT is owned by GlaxoSmithKline, and you need to get permission to use it in the record, and they also have all these tear-off sheets. But the one that is for the older children is owned by Quality Metrics, and supposedly you have to get permission to use that, and also there's a licensing fee for that. That's all I know. We still use it. I guess the question is, have you run into problems with copyright using this in the electronic record? Our medical record people will not place this into our electronic record without addressing this copyright issue.
Well, the way basically is we haven't been scanning in the actual questionnaires into our EMR. We just report the total score, which I'm not exactly sure as far as copyright issues if we can do that, but I'm not aware of any issues with just saying their ACT score, whichever questionnaire you're using, the total score, what that number means. But then of course you lose the details as far as, if you have a score that's in that kind of not well-controlled range, where the issues might be. Is it with exercise versus at night? Kathy, do you have any further information on that?
Do you also, once they've completed the form at the university, do you scan the completed form?
We don't.
You don't? Okay. You just use only the score?
We just use only the score.
Okay.
This is Barbara Seeger on the phone from GSK. I think I can perhaps enlighten some of us around the copyright issues. Actually, it's a licensing piece that we have with Quality Metric in terms of distribution. And as far as the licensing, it requires the PDF format to remain intact, so to speak, so you can't take questions out of it or reconfigure, and that the validation is what was referred to today really is in respect to the format in which it is given. So one of the things that you can do and for an electronic record, for example, would be you can embed the PDF in it. Or I also heard, I think this is a good idea, if you have a total score and you want to trend over time, is to actually just add that number into the note that you have, for example. I don't know if that helps answer the question. And the two types of the ACT are the childhood, the 4 to 11, as we talked about, and also the adult, which is the 12 and up. And those are the two that we can provide once a permission request is submitted to us, as well as a request for use on company letterhead.
Barbara, I think this is Michael Lentz again, we talked in email about this, and
Yes.
I've not had any follow-up from the rep about this. As I understand it, the drug company owns or can give permission for the 4 to the 11-year-old ACT, but Quality Metrics holds the license for the adult. Maybe I'm just confused, everybody, and myself, and that there's two different permissions needed, or can your company address both of those and give permission to have them embedded in an electronic record?
Yes, we can give permission for both. Actually, I'm looking at our permission request form, so it's actually for both, and they're available in English and Spanish.
Okay.
So again, the 4 to 11 and then the 12 and older.
That clarifies it. It begs another question. When we do use these, and I think that the raw number is helpful, our coding people suggest that maybe that's not good enough to use as a coding to charge for it, because we just have a number and it doesn't defend what we did. And so the question is, should we scan these? And so I don't know if anybody else scans these in with regards to coding or billing. And again, I do believe that at risk of putting more junk into an EHR, not that this is junk, but more papers into the EHR, a scanned copy of these might be more helpful than just the raw score.
Yeah, and I don't think there's anything that would prohibit you from scanning that and adding that to your EHR. Again, because you still have it, you have a copy of something that remains intact. I think that's really the question. That's whatever the validation, the reliability of the test is based on the format, and as long as you're just scanning in results, that I don't see an issue with that.
So just to follow up on our email in today, I still need to get the form from you or from the rep.
Right.
To have that signed, and then at that time, after that's signed, sealed, we can embed that, have it in our electronic health record, and or use it in the record.
That's correct. You could take that electronic PDF and you can embed it in your electronic health record. You could also take the electronic form and you could post it on a portal. So for even for your physicians, for example, to access, download, print, or even on a patient portal. Yeah. You could even send it to your patients electronically, for example, via email. So there are lots of ways to use it.
That's good.
Yeah.
We are starting to use a company or a program called Chattis, and that's where patients go in online before coming here and filling out those forms electronically. And I did note that this was on Chattis for our patients to obtain online and to complete even before their asthma appointment.
Oh, well, that sounds great. I'm glad you can use it that way. Very important.
Okay.
Barbara, this is Caffey. I just want to kind of go back over and summarize. You said originally that there were 3 things that you could do with it without permission, I think, right? Without permission. One was that you could not take the questions out individually. They have to remain intact. You can use the score even without a permission. Mm-hmm. And then there was a third thing you said. Was it can you scan the the test, completed test, without permission?
Yeah, once you've got permission to use the form and somebody fills it out, if you wanted to scan it and save it electronically, there's nothing to prohibit you from doing that. And regarding the score, so for example, if they were to take the test and say they had a score of 19, that you could in fact put that in your electronic health record. The score of it was such and such on the state or whatever.
Okay.
As far as coding and billing and any kind of reimbursement around that, I really couldn't address that. So, Michael, I believe that's where you were going with the question. That's something that I can follow up with you on.
Okay. So
Would be helpful.
I do have a question about, you had said that you can give permission for both age group tests. And
Correct.
I had understood, too, that Quality Metrics might have a copyright ownership. Do you have an agreement with Quality Metrics so that that's covered? Is that how you can give permission for both?
Yes, that's actually great understanding. Yes, absolutely. We actually pay. So we have this licensing agreement. We pay a fee to have access to it. So each of the organizations, say Albuquerque Health Partners, would apply or whatever. And then what we would do is take the information, have this permission slip filled out with, again, a letter to say what the intention was in terms of use. We submit it to our paralegal internally. And then we let Quality Metric know that we've, in fact, approved it, and then we pay a fee. And then it's up to the organization to use it.
Okay, so you're paying a licensing fee to Quality Metrics, so it covers the clinics for the use of both of those forms. Okay.
Yes, that's correct. Thank you.
Okay.
Any other questions around that? I think I really appreciate listening today to the presentation and the value of the test. I think it's one of those tests that not only can help establish that baseline, but changes over time in terms of sensitivity, identifying opportunities. And I think the other piece around chronic illness is addressing the patient's perception of illness, which I think is fascinating. Oftentimes patients don't have symptoms and they think therefore they don't have the condition and may not even take controller medication. At the same time, they may be living with symptoms that don't need to be. In fact, could have an improved quality of life. So, again, I think it's an important tool to help manage asthma.
I have a question for Dr. Caffey. I understood that the ACT was validated for filling out at home.
Mm-hmm.
And I don't know if I saw the pediatric version, because if she's talking about, putting it online, and some clinics might have patients fill it out from home.
I don't know on that one for sure. I would imagine it has been, but I'll have to look into that and see if it's been validated for at home or mail, over snail mail use.
Okay.
I'll have to look into that.
Yeah, there is actually another website, and I'm not part of the branded team because I'm a health educator, so I'm not out there talking product, but there is a website out there, I'll just talk generically, where a person can actually access it electronically, and they can fill it out, and there's a score, and then they can also download it, take it with them to their doctor's office. The other thing they can do is actually share results. And I did that myself today. I was out online and had it emailed to myself. So, in terms of any data and how to support that, I can't address that, but I know that there is something available in that regard.
Barbara, that's been very helpful and clarifies the situation for me. You told me that Jackie McCardo was to contact me.
Yeah.
And I have not heard from her. Can you reach out to her again for me?
I absolutely will. I apologize for that inconvenience to you and not really responding timely. And I'll have Jackie reach out to you. I'll actually send her contact information to you as well in an email, and we'll get that addressed.
Thank you.
Oh, you're most welcome.
And I understand that you can write that permission form so it it covers a whole system, right? So I know a couple of my clinics, one from one system and one from another, are both interested in this, and my understanding is, say for El Centro, if someone did that, then all of El Centro would have access to those copyright privileges or use privileges?
Yes, that's how I would put the permission slip out. It would be the organization, and that's cover everyone, and instead of trying to get each clinic at each address, so it would be part of the larger organization. I think that would be the best way to go. And typically it could be 6 to 8 weeks for approval, sometimes a shorter period of time, but that's pretty much the timeline. So I hope that clarifies. It's not always crystal clear, just because of the way licensing agreements and so forth are set up, and we have this other vendor that we deal with. But I hope if there are other questions, I know Caffey has my contact information, so please feel free. Perhaps go through her, or I can also give you my email address, which is Barbara, BARBARA .x as in X-ray .Seeger, S as in Sam, EEGER, @gsk.com, and I'd be happy to, further investigate any questions that you have.
I'm sorry, can you repeat your email address again?
Sure, it's Barbara, BARBARA .x as in X-ray, .Seeger, S as in Sam, EEGER, @gsk.com.
Thank you.
Oh, you're most welcome. And thank you for the invite today to get on the call and also help clarify the use of the ACT, because, part of our goal is to have these tools accessible to providers.
I know we have a lot of patients who speak Spanish, and it was interesting to me to note, and one thing I'll keep in mind is that they might overestimate their control. Is that?
That's what they found. In particularly looking at kids.
I'm sorry, I couldn't hear that last part. A little bit of static.
Oh, we have some background noise. My question, I was just commenting and clarifying that Dr. Caffey had mentioned that there was some ethnic variation in that patients who speak Spanish, or there were a specific subset in Orange County, California, who were of Mexican origin, and their scores were, what do you say, inflated, or
their cutoff score for indicating well-controlled asthma was a little bit higher, and the thinking was because that maybe they overestimated how well their asthma was controlled baseline.
With the interest in disparities, ethnic disparities and so forth, it's so interesting, and I'm just thinking out loud here, but if someone were interested in taking a look at that, even in the New Mexico population, I think that it might be an area that someone would like to pursue. I think it would have value.
Are there any other questions or comments?
And did anybody else join us after we got started, so we can make sure that we have you recorded? If you could just shout out your name, that would be helpful.
My name is Deborah Roberts, and I started afterwards. I'm with After Hours Pediatrics.
Thank you, Deborah.
I know there were a number of people who did join us just after we got started. So if you haven't announced your name yet, please go ahead and do so in order to receive your CME or CEU.
I just want to mention, if anybody's still on, that this collaborative that we're part of is having a spirometry workshop, a full day workshop on June 11th And we are opening that up to folks outside of the collaborative. So for after hours pediatrics or other participants today, if you're interested in the spirometry workshop, please contact me at ALA and I can send you a registration. And my email address is K, as in Kathy, the last name Mosley, Mosley, at Lung, New Mexico, all spelled out, .org.
Great, thank you very much.
All right, well, thank you all very much for dialing in, and our next session will be on April 24th. And the presenter will be Dr. Hangame Racy, who will be talking about inhaled corticosteroids.
Side effects?
And side effects. See you all then.
Bye-bye. Thank you.
Thank you.
Bye.